So let's proceed to the treatment algorithm. So start is the initial diagnosis. So this stage involves the initial recognition that a patient might have a coronary artery disease or CAD. So this can be based on the symptoms or the physical exam findings, family history, and possibly initial test results. So it marks the beginning of the diagnostic and treatment process. So the second one is the symptom assessment. So it includes the chest pain or fatigue. So the symptoms of the CAD often include chest pain or angina, shortness of breath, fatigue, and even symptoms like dizziness or nausea. So this stage helps clinicians to assess the severity and the nature of the symptoms, which provides insight into a possible extent of CAD and guide the risk assessment. This risk stratification. So based on the symptom assessment, patient history and potentially initial test result like blood test, ECG or non-invasive imaging, the clinician categorizes patient into low risk or high risk group. This stratification is crucial as it informs the intensity of the subsequent treatment plan. So let's proceed for the low risk patient. So first is the lifestyle modification. So the patient at low risk for severe CAD complication are first encouraged to make lifestyle changes to reduce the likelihood of the disease progression. So the lifestyle modification includes the diet for reducing saturated fat, cholesterol, and sodium intake. And the next one is the exercise, regular physical activity to improve the heart health, stress management, techniques like meditation or counseling to help manage stress. So these modifications aim to improve overall heart health and prevent complications. So the next one is the medication management for the low-risk CAD patients. So low-risk patients may require medication to control symptoms or risk factors. They may include antiplatelet agent such as aspirin to prevent blood clot, statins to manage cholesterol levels, beta blockers or ACE inhibitors for blood pressure and heart rate control, nitrates to relieve chest pain if necessary. So the goal of the medication management into low-risk patient is to maintain control over the condition with minimal intervention as they are not at immediate high risk for events like a heart attack. So the next one is the re-evaluation with diagnostic tests. So low-risk patients are periodically reassessed to monitor disease progression. So non-invasive tests such as a stress test or echocardiogram may be repeated to ensure the condition remains stable. If symptoms worsen or test results indicate progression, the treatment plan may be adjusted. For the high-risk patients, first is the lifestyle modification. So high-risk patients also receive lifestyle recommendations, but there's a greater emphasis on strict adherence. So even minor improvements in diet, exercise, or smoking cessation can significantly impact their risk. So this patient may receive more intensive support like cardiac rehabilitation programs to assess with lifestyle changes. So the second one is the medication management. So medication plans for high-risk patients are typically more aggressive and may involve higher dosage and combination of medication to manage symptoms and prevent serious events. So this might include high-dose statins to aggressively lower cholesterol, antiplatelet therapy to often a dual therapy like aspirin and other antiplatelet agent to prevent clot formation, beta blockers and ACE inhibitors for the blood pressure control and to reduce the heart strain. So the next one is the calcium channel blocker or nitrates if the patient continues to experience chest pain. So high-risk patients often have closer monitoring to assess the effectiveness of the medication and adjust dosages as needed to reduce immediate risk. So the next one is the re-evaluation with diagnostic tests. So, for high-risk patient, regular diagnostic tests are critical to detect if any signs of progression or instability. So, this patient might undergo stress test, advanced imaging, or coronary angiography to close monitor their heart function and artery conditions. So, further diagnostic tests required. After evaluation, the clinician determined if additional diagnostic tests are necessary. So the goal is to decide if the disease is stable under current management or if further intervention is needed. So if the answer is no, further test is not required. So if the result indicate that the disease is stable, the current management plan is to continue without further invasive tests or procedures. So this patient remain under routine follow-up. So if the answer is yes or there are further tests required, so if further tests indicate worsening disease or if symptoms have increased, additional tests like coronary angiography might be necessary. So these tests help provide a clear picture of the disease's progression and guide the decision on whether surgical intervention is needed. So for revascularization procedures, um, for the patient whose test shows significant blockage or worsening disease, revascularization procedures are considered. So this includes the percutaneous coronary intervention or PCI, also known as angioplasty, where a stent is inserted to keep the artery open. So the next one is the coronary artery bypass grafting or CABG. It is a surgical procedure where blood flow is rerouted around the blocked arteries. So these procedures are typically reserved for high-risk patients or those who do not respond adequately to medication and lifestyle changes. So the next one is the long-term follow-up. So after revascularization, if no further intervention was required, patient enter a long-term follow-up phase. So this stage is crucial to monitor for any recurrence of symptoms and or progression of the disease. So follow-up care includes regular checkups to assess the heart health, continued lifestyle modification and medication management, as well as the possible repeat test to monitor the artery health. So um, the focus on the focus is on preventing future complication and ensuring that CAD is well managed over time. So in summary, the differences between high risk or low risk patient influences the level of intervention. High risk patients typically require more aggressive treatment or close monitoring with a greater likelihood of invasive procedure if symptoms or test results worsen. So the low-risk patient often manage their condition through lifestyle changes and medication with periodic assessment to ensure stability.
Good day everyone, I am Ramona Sogorio and I will be talking about the pathophysiology of the coronary artery disease. First things first, let's talk about the non-modifiable and modifiable factors. First is the non-modifiable factors, which includes heredity, age, and gender. While for our modifiable factors, it includes smoking, hypertension, elevated serum, cholesterol, diabetes mellitus, physical inactivity, and also obesity. While the causative agent for this disease is atherosclerosis. So when we say atherosclerosis, it is the buildup of fats, cholesterol, and other substances ended on the artery walls. So this buildup is also called plaque. The plaque can cause arteries to narrow, blocking blood flow. And what happens after this factor is there will be a dyslipidemia. When we say dyslipidemia, it basically refers to abnormal levels of lipids in the bloodstream. Then, after that, there will be an oxidation of LDL, which leads to elevation of systemic markers of inflammation that will result to an elevated serum ceruloplasmin. After the oxidation of LDL, there will be an inflammation recruits monocytes into the vessel's wall. Monocytes are recruited to the intima by the chemokines, such as the CCL2, and differentiate into mature macrophages mediated by MCSF. Within the intima, the macrophages take up excessive lipoproteins and form foam cells. Then, streaks of fatty tissue can be observed between the endothelium and the smooth muscle layer of the artery. The foam cells accumulate in the intima to form an enlarging lipid core. Fibrous connective tissue accumulates around the lipid core, forming a fibrous cap. Then the foam cells also release many inflammatory mediators. This foam cells accumulation results to the development of atheroma in the artery wall, or what we call the atherosclerosis. So there are three types of acute coronary syndrome: an unstable angina and an ischemia. There is a subtotal occlusion in these two, which leads to decreased oxygen supply. However, in unstable angina, there is a subendocardial ischemia, in which they don't kill the tissues, so there will be negative leakage of troponins, which then results to an ST segment depression or T wave inversion. However, in an STMI, there is a subendocardial infarct. So there are death of the tissues. So when there are death of the tissues, there will be a positive leakage of troponins as a result, which then leads to or results to ST depression or ST segment depression or T wave inversion. Lastly is the ischemia, in which there is a total occlusion, so there will be zero oxygen supply. Then the entire myocardium will be damaged or will become damaged, which we call as the transmural infarct. And this will lead to the positive increase of troponins level, which then results to the ST segment elevation. Another type of atherosclerosis is the stable CAD. In this type, the plaque is covered with fibrous tissues. This type is stable, but the lumen, which is a hollow passageway through which blood flows, is significantly smaller. Because of this, there will be a decreased oxygen supply um, being delivered to the myocardium. But it doesn't necessarily mean that the person will experience angina. However, when the person exerts force, there will be an increase of oxygen demand, which will lead to angina. This person with stable CAD will develop angina once they try to exert force. Our diagnostic exam will include ECG, echocardiogram, exercise stress test, heart CT scan, heart catheterization and angiogram, blood test, and lastly is the nuclear cardiac test. While our medical management will include antiplatelets, statins, beta blockers, ACE inhibitors, um, calcium channel blocker, and nitrates. For the prognosis, the survival rate for CAD depends on a variety of factors, including how severe the condition is and how it is treated. However, with timely diagnosis and proper treatment, the majority of people with coronary artery disease can live long and productive lives. So that's all for our pathophysiology.